Abraham sir. Revati madam, she's the past vice president of the South Zone, and she is the master trainer for a HPV program, and she's the apt person to chair today's session. And Abraham sir, he's like a mentor for me, and I take great pleasure in welcoming you, sir. He was the in charge of the gynae oncology department in Vellore. Sir now has retired and he is now attached to the Narvi Hospital. And when I asked him, he readily agreed. And I also welcome today's speaker, Jayashree Natarajan. She's from Adayar. Actually, Dr. Lata was supposed to do the program talk today, but there's some bereavement in the family. One of the close relatives, she could not join. And she requested Jayashree to do the program, and she also graciously agreed to that. Welcome, Jayashree. And once again, thank you, TNFOG, for giving me this opportunity. And I know you're all there with me to help me in this endeavor. And we will have more and more, monthly webinars in oncology topics. And I welcome all the delegates who have registered for today's meet. And let us take the program forwards. Thank you.
I request Sampath ma'am, who is our TNFOG secretary, to bless us with a few words.
Okay, Radhika. Thank you, Radhika. Good evening. As Dr. Padma told, the TNFOG is doing a lot of academic works, and we do the certificate course and the marathon CME for UAS. And this is the oncology committee work, which will be conducted on last Saturday of every month by 4 o'clock to 5:30. So our Dr. Padma is our oncology committee chair, and our president, Dr. Ramani Devi, will do the welcome address. And on all last Saturdays, please log in into the TNFOG webinar, and you can have a lot of information from Dr. Padma. Dr. Padma will be doing the exclusively oncology webinar CMEs on last Saturday every month this year. We're all the best to Dr. Padma, and thanks for the delegates who have joined. And you can spread the message to others who are not joined, ask them to join in the next webinar. Thank you. And our MOC is Dr. Radhika. She is a quiet person who will accept all things. Okay.
Thank you. Thank you.
Hi, good evening all. Hello.
Thank you. Welcome, Revati ma'am. I invite Dr. Ramani ma'am, our kind president TNFOG, to bless us with a few words and brief about the TNFOG course.
Good evening. Good evening, respected faculties, as well as the delegates for this very important webinar series on gynec oncology. And I welcome Dr. Sampath Kumari, as well as the chairpersons, Dr. Revati Janagiraman and Dr. Abraham, for this meeting. And the program, as Dr. Sampath has already mentioned, Dr. Padma is the committee chair for gynec oncology of Tamil Nadu Federation of OBGYN. So she has planned for a series of webinars every month in the last Saturday exclusively on gynec oncology. I think gynec oncology has now segregated from the general oncology, and it is our duty as a general gynecologist to pick up at what stage we have to refer these patients to the gynec oncologist. The topic chosen today is very apt. That is screening methodologies in the cancer cervix in recent trends. That is again going to be a very, very interesting one, as we have to achieve the goal of 90-70-90. So we have to have a proper screening, proper vaccination, as well as once when the screen becomes positive, we need to have the proper treatment. So because among the incidence of cancer cervix, almost 20 to 25% of the cancer cervix are found only in India. And again, the mortality because of cancer cervix is again 1/4 of the international mortality is from India. So most of our women, they don't reach us at an early stage. And the most important thing is, if the patient is going to suffer from cancer today, the symptoms it could have appeared even 8 to 10 years earlier. So we have a good amount of time for us to catch these ladies who are at risk of developing cancer cervix, and we can prevent the mortality arising because of cancer cervix. So we apart from this program will be continued for at least for a period of 1 year. And apart from this, I would wish to say that TNFOG, we have started a series of webinars exclusively on reproductive medicine and fetal medicine separately, followed by urogynecology and CPG. So all these webinars, nearly 36 speakers are there in each webinar. And it is a paid one because we wanted these people to join the program and continue that, and at the end they will be certified by the TNFOG. And we are also happy to say that the last two programs it will be on not an online program, but it will be an offline program. For example, in people who are attending the reproductive medicine, they can get hands-on training in IUI, they can sit the ART lab. Similar in fetal medicine, I think Dr. Malti will be giving training in the hands-on training for fetal medicine courses. So with this introduction, I am very happy to say that TNFOG, the team is doing an excellent work to spread the knowledge among the doctors. So on behalf of TNFOG, I welcome everybody, the MOC, Dr. Radhika Gauri, who has been doing a very good work, and Professor Abraham and Dr. Padma, Dr. Revati, and today's speaker, Dr. Jayashree Radrajan. Especially, we have to thank her because it was in the last minute she has accepted, and I welcome Dr. Jayashree. With this, I wish the program a grand success. The beginning should be a grand one, and it should continue to go on. Padma, all the best for your ventures.
Thank you, madam. Thank you. But
and we'll be always, TNFOG office bearers will be supportive to you.
Yeah, thank you. Thank you. But then this is going to be a free webinar. This is not a paid one.
Yeah, I know that.
Yeah. No, it's for the rest of the delegates. So I think the chairpersons can take over. Radhika, you are muted.
Revati Janagiraman madam and Abraham sir will be the chairpersons for the talk. Radhika, you can introduce them.
Yes, ma'am. Priya, Sri Priya, can you please post the CV of?
Yes, ma'am.
Yes. So I invite Professor Dr. Revati ma'am, who is the former director in IOG Chennai and Vice President Foxy South Zone, President TNFOG past 2023, and she's founder secretary and past president Madurai OG Society and founder president of. She's also the South Zone coordinator of Foxy ACS HPV vaccine drive, and she's a pride of.
Okay, Radhika, it's enough. Everyone knows I am the past president. Okay.
Welcome, ma'am.
Thank you.
And I welcome Dr. Abraham, who was done his fellowship in gynae oncology, and he's done FRCOG from UK, and senior consultant gynae oncology in Naruvi Hospital, Vellore, and he has huge achievements in this. Welcome, sir. Take over the session, sir.
Okay. Good evening, everyone. It's indeed my great pleasure to just open up this and for the first to chair the first series of this Onco webinar. And I congratulate Padma for taking up this work. And as Ramani was telling that, show the CV of Dr. Jayashree also, please. Okay, I'm actually in Kanpur. I am IMSCON conference. Okay. Jayashree, please. Okay. Now, Dr. Jayashree is MBBS, MS, DNB. She has got fellowship in gynae oncology, and she's associate professor in gynae oncology department, Cancer Institute, Adaya, and special interest in ovarian surgeries, cancer prevention, and cancer research also. And she has received FIGO fellowship in gynae oncology, and also ASGO 2015 Best Free Paper Award and ASGO 2018 OEDS Travel Grant also. And as Ramani said, thank you very much, Jayashree, for accepting the last minute invitation and eagerly waiting to hear you. Over to you, Jayashree.
Good evening, all. Ma'am Jayashree, ma'am, if you're not able to share,
Can you see the screen?
We can see your slides, ma'am. Please make it as full screen.
Yeah.
Thank you, ma'am.
Yes.
Nice.
Today's topic, that is opening topic of the webinar series, is screening methodologies in cancer cervix, the recent trends. Coming to screening in CA cervix, it is an age-old topic. Like we know that countries like US and UK and developed countries, they have been in screening for cervical cancer, and they brought down the incidence of cervical cancer. And their numbers are very limited now, that it is no more a social health problem for those countries who have implemented screening. And WHO has given us a target to implement screening before 2030, and this will bring down the number of cervical cancer patients. So it is the topic of important topic of discussion as on today. There's some problem in progressing the slides. So coming to the recent trends, we know that PAP and via visual inspection with acetic acid were the ones which were used for decades in India. Though the screening was promoted by government side and private practice, due to the cultural and financial problems, we couldn't implement it to the extent what the Western world could achieve. Then comes the HPV invention. This is a major breakthrough. And previously it was, the cervical cancer was associated with the HPV simplex virus infection. Then Dr. Harald Hasan in 1976 found that HPV is associated with it. Mainly HPV 16 and 18 are the two major culprits who's the most common cause of cervical cancer. For this, he was awarded the Nobel Prize also. And HPV later was found to be associated with other cancers like anal, penile, vulvar, and oropharyngeal cancers as well. And HPV invention has become more promising, and it has become the trend in screening. But it has opened up too many new windows also, too many new windows of opportunities and too many windows of confusions also. Why so? Because it's an organism. It has a structure. It has a protein structure. Some are early proteins, some are late proteins. It has a core DNA structure. So we have a list of tests which can be done based on HPV, and the validity of the test and availability of the test and the number of types of HPVs. Then there are more than 200 types of HPV viruses are there. So though we know 16 and 18 are the major types which cause cervical cancer, there are almost 14 high-risk HPV types which can cause cervical cancer. So how to find out them, how to react to each and every test, and all these are developing and still on research topics. We know the persistence of HPV infection is an important cause for carcinogenesis. That is, just by the presence of HPV infection, we cannot diagnose somebody is going to get a cervical cancer. And the infection needs to be persistent enough to cause adequate changes in the cellular surface. That there is a sequence of changes. That is the normal squamous epithelium changing into CAN1, CAN2, and CAN3. That is, the multiple cell layers are getting changes, and then it becomes malignancy. So there is a latent period between HPV infection and malignancy. This may last between 5 years to 20 years even, depending upon the patient's immunogenicity.
Oh, madam.
And can you see the slides? Any issues? And HPV has a causal association with the progression, and it has been found out in all these patients who are manifesting with cervical cancer. But the persistence of HPV is not similar in all the HPV types. We find that 16 and 18 are more persistent and they are more carcinogenic when compared to other types. So when we are screening a person with the HPV test, when we get a result with 16 and 18 and other high-risk HPV types, we may not react in the same way. We have to react more seriously when it comes to 16 and 18, and we have to decide judiciously when it comes to the other HPV types. So when it comes to HPV testing, it is not as simple as VIA or a PAP test, because in VIA, you just see whether some area is picking up acetic acid, it become white or not. And in PAP test, it is a cellular abnormality, which is told by the pathologist to us. That is, the cellular abnormality is this. It may be an ASCUS or ASCUS or an HCIL or LCIL, and we have algorithms accordingly. When it comes to the HPV, we get a result saying that either HPV positive, high-risk HPV positive or negative, and some tests give reports specific for the types. It may be 16, 18 positive, and other HR-HPV positives, or it may give in each and every type. Say it may be giving result like 16 positive, 18 positive, 31 positive, or some all the types specifically. So when we are requesting for a test, we should know what we really want and how do we want to interpret the test. So we know the pathogenesis, we know the way it is going for a malignancy. That is, the HPV genome has to get integrated into the human cell genome, the cervical epithelium. And by the integration of E6 and E7 proteins, they inhibit apoptosis and they increase cell proliferation. That's how it multiplies. So there are multiple ways of finding HPV also. There is one way of finding the HPV-related protein is by finding the surface proteins. The other way is finding out the cellular changes markers. Is there any progression markers like E7 protein or E6 protein, which gives more information regarding the risk of becoming a malignancy. So it started with just finding out HPV. Harald Hudson just found out HPV and he said HPV is the cause of malignancy. And then the research has started in this direction and it's open, it is flooded with research in this topic. Now we know what are the HPV types which are high risk. There are 14 of them and 16 and 18 are the major ones. And to identify these HPVs, we can use DNAs, we can use RNA, we can use surface proteins, and the different ways of collecting them. Initially, when we do a pap smear, it can never be done by a subject itself. The clinician only can do a pap smear. Clinician only can collect a cervical cell because you have to reach the cervix. When a person, when a lady does herself, she may not know where she's hitting with a spatula or brush, whatever they are providing her. But with HPV, the window of screening has opened up widely and the methods of screening has opened up widely similarly. So a lady can test herself. Now we know that we can go ahead with cell sampling also with the HPV test. And these tests are shown to be as promising as the clinician tested samples. And some tests are even coming now, which says that you can find out the HPV presence from the menstrual blood, and even you can use a kit like a NuPT kit, where we can just collect fluid from the vagina and put it on the kit and see immediately the results. So the recent trends are like not only going from one test to another, from PAP to HPV, the recent trends are to understand how to do this better. Whether we need a clinician to do this, can a field worker do it? Can the person who wants screening, they themselves do it? If they want to do it, do they have to have a brush? Can they do it with a tampon or a menstrual pad or with a swab, which can give the sample in a kit-like thing? Can it be so much point of care that immediately you can get a result and treat the patient? So the trend is so fast that we're getting a hell of a lot of information on this. And this has become the most researched topic now, with the ambitious goals of WHO targeting for 70% of women needs to be tested with the high precision HPV test between 35 to 45 years of age. So this has opened up a huge window of opportunity for business people and research people to find a test which will give us a point of care diagnosis. So we know that in the spectrum, we had VIA, cytology, and molecular test. As I said, VIA and cytology were existing, are still existing, and PAP is a major player when it comes to screening in many of the setups. And HPV is slowly coming in. And many places there is a slowness, in adapting to HPV because of the availability of the test, not because we are not confident about the test. And VIA, where does it stand? The Ministry of Health and Family Welfare recommendation published in 2016 has not yet been changed. According to that, screening with VIA every 5 years is a dictum. VIA-based screening is recommended by the Government of India because it's cost-effective and it can cover wider population. And the person doing the test just need to know how to do the test and doesn't need any special equipments. And it is very much cost-effective and acceptable when it comes to periphery. When it comes to pap smear, it is still a player in cervical cancer screening because we have a setup, we have pathologists everywhere in every part of the country. So the existing facilities are still being used. And then comes the HPV test. As I said, there are more than 200 tests existing. And I hope there'll be much more to come into this field. The test and the way we collect samples and everything is going to change over time. So from the right-hand spectrum, we are moving more towards the left-hand spectrum, from visual inspection to cytology to molecular testing. The screening recommendation by FOXI in 2023, as published as an update to the previous FOXI GCPR published in 2018, still gives the cafeteria approach. That is, where there is a good resource, we can go on with primary HPV testing, which is a preferred test. And if there is no HPV facility available, cytology and via are still acceptable alternatives. And low resource settings, if we have a setting where we can't afford to a high-end test, we can use HPV, cost-effective HPV test if they're available, and VIA. So the entire three arms, both via PAP and HPV, are still there, though we are migrating more towards HPV. So what we should know basically why we are migrating more towards HPV is because when it comes to cytology, we know it is 50-50 chance of getting a positive and negative results, and we need multiple repeated rounds of screening and screening at starting at an earlier age, and to increase the pickup rates is mandatory with the pap smear. Though it is very specific, the specificity is like more than 90%, the sensitivity is not as good. And it is compensated by multiple rounds of screening when it comes to pap smear. When it comes to VIA, we know that VIA is more sensitive, but the specificity is less. It can pick up infections and metaplasias as significantly as in malignancy. When it comes to HPV testing, we know it is both arms, sensitivity and specificity are high, and it's very promising that if a person is HPV negative, then repeating the test after 5 years is as good as giving her a statement that you won't get a cancer for next 5 years. So when we are testing with HPV DNA testing, we are very sure that the next 5 years window, there is no anxiety about her getting abnormality in the cervix. That's why there is a shift from cytology VIA to HPV testing. This wide spectrum of test, we see that HPV, invention in 1976 to its first recognition to the hybrid capture 2 in near 2000. And then in the last decade, we have more than 200 tests lining up in the alignment of, in the list of tests which is available for HPV testing. Some are DNA based, some are RNA based, some are miRNA based, some are protein based. So there are a variety of tests. So when it comes to HPV, the next important question everybody have in our mind is when there was a shift from pap smear to HPV, it was co-testing. It was not only HPV testing, which played as a transformation role from the pap smear. In that we know that PAP is working, and we took HPV also as a confirmatory test, and we took both of them together. Now we know that doing that is not cost effective, and HPV is as promising as a screening test also. So HPV testing as a primary screening method has a high sensitivity, that is more than 90% as we know, and a high negative predictive value, more than 98%. This allows safe prolongation of the screening interval. So we can prolong the screening interval every 5 years, and in resource limited setting, even if the woman is not coming back again for a decade, we are sure that she's not going to get into a malignancy before we go in for next screening. So the HPV testing is coming as a primary recommended primary screening method for women more than 30 years. Why 30 years when it comes to pap smear 21 years? It's because the chance of having a HPV infection is more when in the third decade. And we want to know the persistent HPV infection than any opportunistic HPV infection which may be cleared by the body. So testing with HPV for women more than 30 years is a recommended way. If someone wants to get tested less than 30 years with the HPV test, then if you have a type-specific test, that is a test which gives results along with the HPV positivity, which type of HPV is positive, then that is recommended than going for a simple HPV testing in a woman less than 30 years. What I'm saying is the best way is to go with the primary HPV testing in women more than 30 years. If you want to do it for women less than 30 years, choose a test which gives type also along with it so that we can interpret the test better. For women who are immunocompromised and HIV positive, the screening should begin with 25 years with HPV testing if you're going for a primary testing. This is a small list of tests which are most commonly used in many of the setups. The list is more than 200, as I said. And this hybrid capture 2 is the most commonly done test, which gives results saying that HPV positive or negative. It doesn't give any type specificity. The Cervix, CARE HPV, COBAS test, about real-time high-risk HPV test, the PIT HPV poofer, Aniplex, Expert, C genes, and Aptima. There's a variety of tests based on HPV DNA signal amplification or PCR based or mRNA based. So we have a list of them. The problem is which to choose when we want to go for it. So to know more about the test, we need to know which is good. So when it comes to hybrid capture, the sensitivity and specificity is quite good, and most of them, like in the test list, CARE HPV, Cervista, COBAS, RT-PCR, Aptima, and Expert, all of them have a sensitivity more than 90%, as you can see from the slide, and specificity is also more than 80 to 85%, all of them have. So the performance wise, these tests, these are the US FDA approved tests, and these are widely used in multiple places. They have comparable performance. And we have a list of tests which are made in India. They are coming as in cheaper alternatives for the tests which are coming from abroad. They are the TrueNet HPV test, Petho Detect test, Tata MD Check HPV test, and HVQ POV, and comprehensive RT test, and True PCR test. These are tests which are coming up in India. Some are available already in market, showing their showing their performance. I have a table that we find them that they are also equally performing, but we should have a good validity and a good sample size before we are choosing any test into our own lab, because the test which we are providing should give a result which is reliable also. So how these tests are tested, when 200 or 300 tests are coming into the market, and how they are tested, there's a criteria called as Majors criteria. It says as a clinical sensitivity for a test. That is, if you're using a test, the test should be able to detect more than 90% of CA in 2+ lesions in women more than 30 years, and at least 60 samples should have been tested before the test is coming for a market purchase. And the clinical specificity of the test should not be less than 98% in women more than 30 years. At least 800 samples should be tested for this. And intra-laboratory variation also should be considered before the test is being accepted as a Majors criteria positive test. So any lab person or any person who's coming to us, a business person who's coming and telling us, please take this test to your hospital, we should see that whether they are approved by any regulatory bodies, either it's US FDA approved or Indian regulatory authorities approved. Has it cleared these Majors criteria? Do they have any publications to support that? So when it comes to screening for a general population, to use HPV DNA testing as a primary screening test rather than a VI and cytology, quality controlled cytology screening can be continued until HPV testing is available, provided we choose a quality controlled HPV test also as an alternative to a pap smear. VA-based programs can rapidly change to HPV screening when the facilities are available and when the facilities are made cost effective, and to use HPV DNA testing with or without triage to prevent cervical cancer. So to summarize, in general population, we can start screening with HPV at the age of 30 years with a screening interval of 5 to 10 years based on the resources available. And it can be used as a primary test, and we can try and treat as per the guidelines available for us. So how to proceed once we know HPV test is positive, how to proceed with it? We have adequate algorithms for interpreting it. We don't have to panic like how to interpret HPV test. We have algorithms produced by Foxy, and we have algorithms produced by WHO also. These algorithms are for every situation, like you're screening with HPV primary testing or co-testing, or doing a VIA testing, or doing a cytology-based testing. These algorithms are available, and they take us step by step. We don't have to have a confusion in any step. It gives all possible options what all can be done, and what are the results can be available, and how to proceed with it. So there are 7 algorithms published by WHO. It is available in the WHO website. These algorithms gives clear-cut how to manage with it for those women who are immunocompromised and those who are with a normal immunity and the general population. So these algorithms are very clear-cut, and there is no confusion in managements. So when it comes to treatment recommendations, we know testing and how to interpret the test based on the WHO and the Foxy recommendations. We have charts. We can go to the charts anytime and we can see how to manage them. And when it comes to treatment recommendation, we can have an approach of having a biopsy and interpreting it and taking the person for a management. That is the right way of doing it. That is the standard way of doing it. I can't say right way, that's standard way of doing it. But when we are going for a mass screening, when we want to go for a screen and treat approach where we know the result and we are treating immediately, it is also possible even with HPV if the results are available in the same day. In a screen and treat approach, screen positive women are treated without any histological diagnosis. That is screen and treat. The treatment modality can be ablative or excisional. When it comes to ablation, we have a set criteria. Who are the patients who are fit for ablation? That is, the lesion should be small enough to ablate it, and it should occupy only less than 3/4 of the cervical quadrants. and it should not go inside the endocervical canal. It should not be going to the fornices, and there is no evidence of malignancy. If these clear-cut criteria, if we check box each of them and find out the subject is good for ablative, then the subject can be taken for an ablative treatment. If you have any suspicion of any of these, then the subject has to be referred for an excisional treatment. And there is a problem in treatment that when we are going for screening, that we know that the subject is having HPV positivity, or we have a Gaia positivity or a screening test positivity, we should make a target that we should treat this lady within 6 months of our screening. It may be a general population, HIV positive population. So the tracking the positive reports and providing the treatment within 6 months is essential to give the right treatment. If a woman is pregnant when we are screening and we found abnormality, the treatment can be deferred till delivery. For histologically confirmed adenocarcinoma in situ of cervix, the recommended treatment is loop excision or cold knife conization. We don't provide any ablative treatments. When it adeno, it is only excisional treatment. And the treatment doesn't get over with whatever we are providing. It may be screen and treat approach, or screen, see and treat approach, or do it with the biopsy, whatever way. It is to be followed up with the after treatment for visit, at least 12 months after the treatment. And the preferred test at that time is HPV DNA testing. If the test is negative, the lady can go on for a regular screening. So it is not one-time contact. We are screening, then we are tracing them for the treatment if they are not being treated in the same visit, and then we have to have a after treatment follow-up also. So all three are important when we are coming to screening, that we should be able to keep her on follow-up for at least 12 months. This is possible only if we have a contact address and at least 2 phone numbers with us. That's how we follow in our setup, that she is not getting out of her loop for any management. So the follow-up algorithms are also very clear in WHO and FOXC, that how we are going to proceed with women who are having any abnormality during the 12-month follow-up visit. So to choose a test, we need to think. But when after we chosen a test, when the result comes, there is no hesitation. Many when we go for a talk, when they ask us like how to treat HPV positives, we don't have to think. We have set algorithms. It is available. We just have to have a chat and see what to do with it. And then after 12 months, when the subject is coming for a test again, for a test of cure, after 12 months, that time also what to do is not a question, because we have proper algorithms for it. So what we know today is the evidence is strong that persistent infection is the reason for cervical cancer, and HPV test is a good test. It is developed for based on evidence, and we have enough evidence right now to switch over to HPV test. And HPV tests are proven to be superior to cervical cytology and VIA in detecting cervical precancers. And the sensitivity and specificity are very high, and negative predictive value is very high. That switching to HPV is the best possible way. And when we are switching to HPV, now it is not co-testing, it is primary HPV testing, which is more suitable for any setup, including those who are immunocompromised. With this, we will be able to achieve the 70% target for WHO. That is why the word high precision test, which by WHO definition is HPV test, is being indicated when it comes to the elimination targets by 2030. So we see the time trends in USA. The test was started initially when they started introducing HPV testing, it was reflex testing. Then they found HPV is working, then it became a co-testing. Then it is moved from there to the primary screening testing. Now it is going ahead, still more further. There is a point of care testing where we can test and treat also in the same sitting. So HPV has grown over the years and shown its trend more promising from reflex testing, co-testing, primary screening test to point of care testing as on today. So the data from West and the data from India are more reassuring to adopt HPV test. So now we'll go to some set of slides which shows what is good, bad, and ugly about HPV testing, because we've spoken so much about HPV and saying that that is the only trend now. So what is good about HPV testing is it is well suited to address the barriers to screen in low resource setting. That is, it expands the interval between testing. So it is very important that when we are going back and back again to a community and test the women in a regular frequency, it is very difficult. So HPV has brought down the frequency of testing, so brought down a big barrier in that. Second way, self-testing is possible with the HPV. So it is more promising now as an acceptable test in women who are culturally inhibited to go for a testing. So there are a lot of barriers which is being broken by HPV testing. And it provides the same extent of safety with fewer rounds of screening. Even one test with HPV between 35 to 45 years can bring down the incidence of cervical cancer. Point of care HPV testing allows for a round of screening to be accompanied in 1 or 2 visits. If we are getting tests like what I was explaining, like if we have a strip in which we can put a HPV and sample and find out HPV positive or negative, that will be the best way to go ahead in the future, because we'll be able to treat in the same sitting a woman who's coming for screening. And HPV testing is possible by self-sampling. It is the best advantage of it. Even those who are educated, they are preferring self-sampling kits than a clinician taken sample for HPV testing. And implementation of HPV testing as a primary testing overall has shown in the developed world, if we implement the same results, we replicated in our setting also. So coming to HPV, the next question is, first fear was about which test to choose and how to manage HPV positives. If these 2 questions are answered, the next question is frequently asked is it cost effective? Will my patients be affordable when affording to it? We have found that in paying group and in free setup, where the screening is provided by the government, it is in public and private, any setup, HPV testing is cost effective because it reduces the number of times the screening test has to be done, the visits on the work schedule and absenting from the work schedule and all this together. When you calculate, the HPV testing is cheaper. If it is given as a self-sampling, it will be more cheaper than even clinician-collected sampling. So if it is screening, then the most cost-effective way, as on today, if you calculate everything together, is HPV. The next question is, should we go for some other trials test along with it, like a PAP along with the HPV, or should we do as a primary screening? This, as I explained earlier, we have enough data now to say that it is good as a primary screening test. Is it a good test to implement in a country like India, where we have 50% of population women? The targeted age group for screening is so huge. So if you do a modeling study, the results are so much promising even for a developing country and underdeveloped country. Going for a HPV-based screening is more cost effective than going for other ways of screening. And can it be used as a point of care test? We have enough data to show that it is good as a point of care test also. So as I said, if you're going as a self-sampling method, it is the most cost-effective way of screening, because we can distribute this self-sampling kit to the women in the village and collect them together, and we'll get a whole lot of samples together to run. And it will be more useful to find out how effective it is in a community, the barriers also. So we now spoke so good about HPV testing that we know that it is the word of this decade when it comes to cervical cancer screening. So what is bad about HPV testing? We are shifting from an age-old technique like pap smear, which is now we are so much tuned to its results, and we have standard cytologists and pathologists who can pap smear. Going from a promising test standardized to another test. Picking up a standard test is the challenge when it's coming to HPV tests. There are more than 200 HPV tests. Majority are not validated, and many are not as per the approved standards. So choosing an appropriate test is a challenge. And one more challenge, even for an institute which is set up and established, is we have a hybrid capture. Then comes a test called COBAS, which gives the results specific for 16 and 18, another HPV. Then within 3 or 4 years, then comes another test which gives every HR types, like it gives even 31, 45, and everything it can say. So investment on a test, HPV-based test for an institution is also a questionable thing. Like how much to invest, it is getting updated every 3 to 4 years. This can be avoided by having a hub and spoke model. That is, we don't have to invest on every set of instrument coming for HPV testing. For every recent facility, we don't have to invest so huge on it. We can have a hub and spoke model wherein a facility where a recent test is available, which we prefer is there, we can send our samples and get our results. This will be the most cost-effective alternative for those who are establishing the equipment and those who want to get the results satellite from them also. By the satellite approach, when samples are collected from multiple places to a hub, then cost also comes down and the turnaround time for giving a report also comes down. And the standardization and other problems with the test will be done properly. So when it comes to this critical point of choosing which test and how much to invest on HPV test for a hospital, I think the hub and spoke model will take about this bad part of HPV testing. So this is the list of tests which we discussed earlier, which is approved and it is available, and we know these are the standard tests. So if some other test is coming, how to know it is the standard test? The selection is based on, we should know the name of the assay, whether it is published in internet, who's the manufacturer, have they got any approval from any of the regulatory bodies in US, Europe, or India? When it comes to India, it is CEDESCO approval. Is there any clinical validation? Is the test is relative accuracy against standard comparators are done? What is the principle of test? What basis the test is running on? It's DNA based, RNA based, or protein based testing? And what is the range of genotyping it is testing? What is the turnaround time? And how many samples it can run? It needs to give a result in a time. And will it be suitable for our requirements? Say if I want to take a test to a field, will the equipment need electricity? Will it be working in the hard environment where I'm going to take the equipment and go? Will it be able to get the same result in a standardized air-conditioned room on the field in the same way? And can it be used for self-collected samples? Can it use samples like urine and other things which we're trying to test now for HPV? And what will be the cost per sample? So all these things need to be discussed before we invest on a test or we ask for a test. That's why I say if you have a hub and spoke model, this problem can be avoided. So that the standardization of the existing test is also possible, and updating to a better test is also possible for HPV testing. So we found that low-cost test from India, TrueNat, PathoDetect, Tata MD, HPQ POV, and True PCRs. These are also available tests. And we had a PCR-based testing during COVID times, and many of the PCR tests in the MTB PCR labs are also available. Some of the government setups are trying to utilize this for HPV testing, but this is a good alternative to than a pap smear. But these tests need to be standardized before we are validating giving these results to screened population. What I am saying is, if you are changing an existing equipment which is being used for MTB PCR or Cobas test, a PCR machine to HPV testing, then before we are confidently giving a report, we should at least standardize it with a standard test, and then when we are confident enough, then we can convert them for HPV testing. The ugliest part of HPV testing is when it comes to pap smear. Most of the time, when we describe this to the subject, is in Tamil we say garbapai vaila punnu irukku. That is, we say there is a ulcer in the cervical mouth of cervix, which needs to be treated. So there is not much of a discussion with the screened population or their partners regarding how it came there. But when it comes to HPV, with the current awareness about virus, the COVID has brought in a lot of information about the virus and virus types and the way they're spreading. If you say you have to get a HPV test, the immediate question is, what is HPV? When a test is told positive, then the subject and the partner wants to know how somebody got the test, how somebody got the infection. And next possible worry is, will I get cervical cancer? And if the test is positive and we say come back after 1 year, we want to know whether the virus is persisting or not. The screened population is so skeptical to know the ways and means of getting rid of virus. They want to know what is the dietary changes, what are the personal change, and what are the other sexual behavioral change which needs to be done to get rid of virus. And they want to know will it affect the partner also. And they want to know whether the partner needs to be tested, wherein we don't have any testing for male partners. So they want to get vaccinated. Now we know the vaccination is not going to help married women as good as those who are unexposed to HPV. So we need to be ready to answer these questions when we are advocating for a HPV test. We need to be prepared. Every subject, in a hospital setup or a screening setup, when we say you're HPV positive, These are the repeated sets of questions we need to be answered. So this was not with VIA and PAP. So this is the ugliest part of HPV testing. So though HPV is more promising, we need to increase our awareness about the types of HPV test, the way they are done, the standardization procedures, the turnaround times and cost of it, and how to reduce the cost by clubbing the samples together or adapting to a hub and spoke model, and how to interpret the test results and how to manage it. It is not a single time test. It needs testing, it needs treatment, it needs follow-up of 12 months. It's like 1 year thing if you are calling somebody for a screening. And how to switch your existing setup from PAP and VIA to HPV. And all these are the areas where we have to improve our knowledge and have more doubts and have more queries and more questions and answers and switch from one to another for a definitive good purpose. So the take-home message is we need primary HPV testing. We know that. We know it is cost effective. The solutions will be better and we'll be able to broaden it if you have low cost kit, if it become point of care, and we adapt to self-sampling and we can adapt to single visit approach. We have a team for pre-test and post-test counseling, or we have any prepared material for the same. Then we are all good to go from VIA and PAP to HPV. Thank you.
Thank you, Dr. Jayashree, for the very informative talk, and also, cautioning us about when we jump right to go into HPV testing area. Just like to say that we have to be careful about population-based screening and the hospital or clinic-based treatment of patients or evaluation of patients. So that's something that we have to always keep in mind. So many things that Dr. Jayashree talked to us about was about population-based screening. Any questions? Let's look at the chat box. Any preferable day of cycle to test HPV for DNA? Jayashree, is there a particular time of the menstrual cycle where you should test?
Probably post-menstrually. The subject can come anytime and get tested. But if it is taking an appointment and coming, preferably post-menstrually. Even menstrual blood can even give a HPV sample. HPV sample can be taken with the menstrual blood also. So there is no specific timing in the menstrual cycle, but preferably post-menstrually if we can give an appointment too. As sir said, most of the talk in my slides were for adopting from primary via PAP to HPV testing. When the main inhibition for those private practitioners to go from PAP to HPV is availability of the test. So if you find a center where you can send your samples to, this problem can be avoided.
Very nice talk, Jayashree. Few more points to this thing. One is, what about testing male for HPV? Many patients are asking about it.
Right now, we don't have a standardized way of testing male partners for HPV, ma'am. And but vaccinations are available for boys. But
yeah.
not
Okay. And another thing is that this self-testing, though it appears to be a very fancy thing, but how many do you think that they will accept it and they are practicing it in, at least in your setup? Have you seen anybody accepting this test? Even doctors, when I offered, they said they are not coming forward. Okay.
What I found the other way, ma'am, when we are offering self-sampling, I mean, the health workers are more comfortable being checked by
okay.
than I don't know about general population. General population, the people working, I mean, our team working in general population, they say acceptance is good, even for general population. But health workers, somehow they hate the couch. So they don't want the couch and they don't want to be examined in the setup where they're sitting in. So they're preferring self-sampling, including our postgraduates who are doing MCH and DM, those who are married and want to get screened. They are always behind self-samplers than coming to the clinician testing.
That's really
speculum
nice.
examination is the most uncomfortable thing. So it avoids speculum examination.
Sampling, self-sampling is more in our setup, even in a hospital where they're scared of cancer. They prefer self-sampling than clinician-based sampling.
Yes, that was an awesome presentation. You brought out all the newer trends. in screening, especially HPV, because many of us are not used to HPV in our regular day-to-day screening activities. It's good you brought out all those things, but you were saying something like a dual testing even for our PAC test, isn't it? Can you throw a little more light on that?
Sorry, ma'am?
Dual
Co-test.
Co-testing.
Co-testing.
No, not
Saying
co-testing, it's dual testing, no? With KI.
No, we mean markers. Okay, what I mean, they are not for the what to say public screening, and they are for testing in a private setup, in a bit upper level of private setup. It's not for public screening. We have markers like E67 and P16. These are markers which says that the cellular abnormality has changes due to HPV infection also, which has a chance for propagation to malignancy. This dual staining, these help us to know how much chance of them having more risk of malignancy. But this is not for public screening. They are not cost effective at all. So when it comes to screening, I didn't pick up the words specifically because we're talking about how we are going in a trend. We are not going towards the dual staining. We're going more towards HPV screening. And the next thing what you told is like where to send sample. Like I think CMC Vellore also accepts sample from outside. Nadir accepts samples from outside. So centers where they have equipment, they are allowing samples from outside to be received and tested. So if you don't have to have your own setup for HPV testing. You can send the samples. There are enough of collecting ways are there. The lab people itself, like the Roche and other people are collecting samples from the clinicians and sending us across, like from Coimbatore, Bangalore, and every place. And then even in multiple clinics in Chennai, they're sending samples to us. So you don't have to worry about where to send it. You just have to find a place, find a patient to test it. That's it.
And P16 and P37, any specific indication, say for example, after conservative surgery for this pre-malignant condition and so on, that will be of much use, where you expect that there is a possibility of going to malignancy and all. So is there any specific indication for those tests? P16 and 37.
It's like whoever is like going for a surgery for pre-malignant condition, if CAN2 and above, they need to be followed up for 20 years at least with the screening test annually. And any screening test now is moving towards like whatever we say, like we have a test and we had an ablative or excisional therapy. A 12 months follow-up, we are offering them HPV test to know the persistent of infection and to know whether this is cured. The same way, even those who are undergoing surgery for a pre-malignant condition, the preferred test is HPV testing.
Okay, thank you.
Okay, and then you had highlighted this, HPV testing in a general way after 30 years and type specific before 30 years.
Because if it is less than 30 years, if you have a high risk HPV positive, say a 25 years old lady is coming with a persistent discharge and we were testing for with the HC2 hybrid capture 2 and getting a result say positive, this may not lead us anywhere. Then you need to your report, that at this age she has a chance of clearance of HPV and she's supposed to have this infection at this age. Many of them will have infection at this age. So if you have a type specific testing, say 16 or 18 positive, that gives more directions whether she needs Calpo immediately or whether you can call her after a year for testing.
And among the available Indian tests, which is a better one? Listed many, no?
Yes,
which are you using it in Adyar or what is sir using in Vellore?
We have hybrid capture 2.
Okay.
And then we got the Cobas because it gives 16 and 18. Now we've gone with C genes, which gives size specific. And in field in Viluppuram, we have Gene Expert. So we have the entire mission spectrum. And they had, in Viluppuram, before that, they started with the carriage HPV as a PCR based testing. Now they have Gene Expert. They're in Viluppuram.
These tests that Jayashree is mentioning are, FDA approved tests. The Indian tests really have not been standardized. So maybe the TrueNat by Malbio people are using. But
And Tata MD is also
tests are not really. The point of care testing is usually the Gene Expert, the CAFE, but which limits the number of patient samples you can test at one time. You have 2 cartridge, 4 cartridge, 8, 16. Probably 16 at this time is probably the maximum number you can do. So there are some advantages and disadvantages.
But in that case, many of our practitioners are sending it to their labs where they get it done, just like Anderson or somewhere? And how far what is the reliability of those tests? Without that, they are just treating the patient.
So when
Yes,
we
that's why, you have to be careful about HPV testing because it is a sensitive test, but doesn't mean that how do you see, one of the questions in the chat box is what do you do with a positive test? So because it's a very sensitive test, like Jayashree mentioned, in younger age group, it is not very reliable. It is in the older age group where, it suggests persistent HPV infection. So having a HPV positive itself doesn't mean that, you have to do something immediately. You may need a triage test or some strategy to decide whether to do genotyping or cytology or VIA or, so there has to be some, you cannot just, of course, in a population-based large screening program, you might do, like in Bangladesh, they're doing HPV test and then treating everybody if they are positive.
Yeah.
But
Actually, in
then there'll be a
Foxy, we
lot of
have got a
overtreatment.
clear-cut guideline in flowchart also. Just if you do a pap test, if you do this HPV, next, what next to do. Similarly, we've got a clear-cut flowchart which will definitely help all.
Foxy flowcharts came earlier than WHO flowcharts. Abraham sir and me were also there.
Okay.
Yeah.
That's
And
nice.
what I'm trying to say from beginning is everything starts from choosing the test. Switching to HPV is one thing, and choosing the HPV test, from there the entire smartness starts. If you really want to answer the question what to do, then you should know what you want to do with what kind of result you want, basically. If you have a test, at least it gives 16 and 18 positivity and other HR positivity, then the triage risk is not there. You don't have to go for another triage test. 16, 18 positive, this is how you're going to treat. Rest of them, how we are going to treat. This is there in the flow chart. If you have a test which is not type specific, it just gives a high risk positive, then your chances, your management scope is also limited. So from the test which you choose, from there the journey begins there.
Correct.
So if you ask me which one I will choose, I will say it's something which gives me 16 and 18 and positivity with other high risk positivity. So we have Cobas test which gives such result, and we have C genes which gives every type positivity, like whatever type. So I prefer both of them.
One more question, Jayashree. Say somebody you have treated for CIN2 or HSIL with resection, and how do you follow up these patients? Would you choose cytology testing, or once again will you go for a HPV testing?
HPV testing. The preferred is HPV testing. After a year, doing a HPV testing is a preferred way.
Okay.
Just to keep in mind that because HPV test is good to rule out, a negative test will rule out disease. And for cytology being more specific, it's better to rule in disease. So just keep that in mind. But both the tests are good in certain situations. I don't think we can write off cytology completely. Cytology also has a place in the clinic, especially, not for screening. I'm not saying population-based screening. In the hospital setting, there is a role for cytology also.
So since many of us do opportunistic screening in the hospitals, which do you think will be a better test? PAP or cytology or HPV testing?
HPV.
Okay.
So as JC rightly pointed out, HPV is the primary test nowadays.
Yeah.
So everywhere.
Yeah. I just want the message to get across.
Yeah.
And I feel that all the gynec should switch from, including me, so switch from opportunistic screening to putting a board saying that where screening is available for cervical cancer. That's how we can reach a 70% goal. Otherwise, with opportunity, we'll be nowhere.
Ma'am, but in public health setups, I'm in ESI hospital, ESIC. It's quite costly. It comes to around 3,000 per patient. Yes, it's quite costly.
Which one, ma'am?
HPV, ma'am.
Which test specifically we are giving?
Cobas, actually, they are doing.
Okay, Cobas in our setup, they're charging for outside samples 1,400. So our samples will be coming down even for 1,100. So you can find a better place to send, actually. It's not
We are doing it through Anderson, ma'am.
That's what I'm saying.
Yeah. But in government setup, it is highly impossible. Government setup.
Labs is they need so many number of samples to run when it comes to Cobas test. Platform is the 3,800 or 5,800 platform. They have a set of 96 samples or sample size. So they have to work tremendously to bring in the sample faster to give you the result in the set time. So the manpower cost also comes in your billing only.
All right.
So when there's a pooling in a place, to give there is better because the cost will come down. Obviously, the effort of manpower is coming down with our effort of sending there.
All right.
Just we are asking the government to bring in vaccination. We should also ask the government to bring in the HPV testing.
Actually,
Free of cost.
the government of Tamil Nadu, NHM was trying to bring in, ma'am. Actually, they're trying to bring it into Omandura. They're saying that they're trying to bring in the stock.
Okay, ma'am.
Okay.
Padma, ma'am?
Thank you. Very nice, Jayashree. Excellent talk.
Thank you, Dr. Jayashree. It was really an eye-opener. Only message is whenever you happen to see a lady, please don't fail to look at the breast and look at the cervix.
And the second thing is display that we do screening here.
Yeah. Okay. Then finally, I would like to small documentary film, which will not take more than 6 to 7 minutes, that was prepared by Tamil Nadu Federation of OBGYN and Dindikal Society. Okay, which I would like to share, and I think this you can.
That's beautiful video, sir. We should see. I've seen that.
Yeah.
Nice video.
Priya,
Priya?
are you able? Priya?
I'll call it.
Priya, do you have that?
I'll call Priya.
I'll just share it.
Okay, ma'am. பிரியா அந்த இதை மேடம் ரமணி மேம் அந்த வீடியோ போட சொல்லியிருக்காங்க.
Are you able to see now?
Yes, ma'am.
Yeah.
Yes, please.
Yes, ma'am, we are able to see. Thank you, Bob.
எது சிறந்தது வரும் முன் உண்பதாய் வந்த பின் வாழ்வை இழப்பதா?
பெண்களிடையே அதிகமாக காணப்படுகின்ற இந்த கருப்பை வாய் புற்றுநோய் ஒரு சாதாரண தடுப்பூசியினால் குறைக்க முடியும், தடுக்க முடியும் என்று இருப்பதால் இதனை சரியான பருவத்திலே பெண் குழந்தைகள் அனைவருக்கும் செலுத்தி இந்த கொடிய நோயிலிருந்து நம்மை நாமே காப்பாற்றிக் கொள்வதற்கான ஒரு சிறிய முயற்சி தான் இது.
ஒவ்வொரு 8 நிமிடத்துக்கு ஒரு பெண்ணும் நாளொன்றுக்கு 200 பெண்களும் இந்த காரணத்தால் இறந்து கொண்டிருக்கின்றனர். இந்தியாவில் ஆண்டுதோறும் சராசரியாக 1.24 லட்சம் பேர் இந்த பாதிப்புக்கு உள்ளாகி வருகின்றனர். தோராயமாக 15 அல்லது அதற்கு மேல் வயதுடைய 51 கோடி பெண்கள் இந்த பாதிப்புக்கு ஆளாகும் அபாயத்தில் உள்ளனர்.
பெண்களுக்கு அநேக வகையான புற்றுநோய்கள் ஏற்படுவது உண்டு. இதுல எந்த நோய்க்கும் தடுப்பு ஊசி கிடையாது. ஆனால் இந்த கருப்பை வாய் புற்றுநோய்க்கு மட்டும் தடுப்பு ஊசி மார்க்கெட்டிலே உள்ளது. அதனால இதை தடுப்பதற்கு அனைத்து பெண்களும் 9 வயதுக்கு மேற்பட்ட குழந்தைகளுக்கும் இந்த ஊசியை கொடுப்பதன் மூலமாக அவர்களை இந்த புற்றுநோயிலிருந்து நிரந்தரமாக நம்மளால் பாதுகாக்க முடியும்.
இந்த ஆபத்து பெண்களுக்கு மட்டுமா? இல்லை, 15 வயதை கடந்த 3 1 ஆணுக்கு இந்த தொற்று ஏற்படுகின்றது. இந்த புள்ளி விவரங்கள், செய்திகள், பாதிப்புகள் உங்களை பயமுறுத்த அல்ல, பாதுகாப்பதற்கு. அந்த பேராபத்து HPV வைரஸ் தொற்று. இதனால் உண்டாவது புற்றுநோய். HPV வைரஸ் தொற்றினால் பெண்களுக்கு கருப்பை வாய் புற்றுநோய், ஆண் பெண் இருபாலருக்கும் பிறப்புறுப்பு, ஆசனவாய், தொண்டை ஆகிய இடங்களில் புற்றுநோய்களும் பிறப்புறுப்பில் மருக்களும் உண்டாகின்றன. ஒருவருக்கு HPV வைரஸ் தொற்றிய பிறகு அது மனித உடல் செல்களை கொல்வதில்லை. அதனால் நமது உடலின் நோய் எதிர்ப்பு மண்டலத்தால் இந்த வைரஸை அடையாளம் காண முடிவதில்லை. நோய் முற்றிய பிறகே தெரிய வரும். கருப்பை வாய் புற்றுநோயை ஏற்படுத்துவது HPV வைரஸ் மட்டுமே. கருப்பை வாய் புற்றுநோயால் பாதிக்கப்படும் அபாயத்தில் இருக்கும் 15 வயதிற்கு மேற்பட்ட இந்திய பெண்கள் 483.5 மில்லியன் பேர். இது உலக மொத்த பாதிப்பில் 17%. ஒவ்வொரு ஆண்டும் புதிதாக கருப்பை வாய் புற்றுநோயால் பாதிப்புக்கு உள்ளாகி வரும் இந்தியர்கள் 1,23,907 நபர்கள். இது உலக மொத்த பாதிப்பில் 21%. ஒவ்வொரு ஆண்டும் கருப்பை வாய் புற்றுநோயால் மரணத்தை தழுவும் இந்திய பெண்கள் 77,348 பேர். இது உலக மொத்த பாதிப்பில் 23%. அதாவது கருப்பை வாய் புற்றுநோயால் உலகில் மரணத்தை தழுவும் பெண்களில் 4 ஒருவர் இந்தியர். நோய் வந்த பிறகு மருத்துவமனை, சிகிச்சை என உடல் மன வேதனையையும் பொருளாதார நட்டங்களையும் தவிர்க்க வேண்டுமானால் வரும் முன் தடுப்பதே சிறந்த தீர்வு. இதற்கு உலக சுகாதார நிறுவனம் பரிந்துரைக்கும் ஒரே நோய் தடுப்பு நடவடிக்கை ஹியூமன் பாப்பிலோமா வைரஸ் வேக்சினேஷன்.
போலியோ அம்மைக்கெல்லாம் நம்ம தடுப்பூசி போட்டு பழகிட்டோம். அதனால இப்ப போலியோவே நிறைய பேருக்கு இல்லாம போயிடுச்சு. அதே போல கர்ப்பப்பை வாயில வர புற்றுநோயை தடுக்கிறதுக்கும் தடுப்பூசி இருக்காதான் HPV வேக்சின். அதையும் போட்டு நம்ம பழகிட்டோம்னா கர்ப்பப்பை வாயில வர புற்றுநோய் வராம இருக்கும். கர்ப்பப்பை வாயில புற்றுநோய் வந்ததுக்கு அப்புறம் ஊசி போடுறதுன்றது வேஸ்ட். அதனால நம்ம வருமுன் காப்பதுக்கு HPV வேக்சினை வளரிளம் பருவத்துல போட்டு வராம தடுப்போம்.
9 முதல் 14 வயது வரை உள்ளவர்கள் 6 மாத இடைவெளியில் 2 தடுப்பூசிகள் எடுத்துக்கொண்டால் போதுமானது. நீங்கள் 15 வயது முதல் 45 வயதிற்கு உட்பட்டவர்கள் என்றால் 2 முதல் 6 மாத இடைவெளியில் 3 தடுப்பூசிகள் போட்டுக்கொள்ள வேண்டும். இந்த தடுப்பூசியினால் பக்க விளைவு எதுவும் இல்லை, விலையும் அதிகம் இல்லை.
அனைத்து பெற்றோர்களும் தன் பெண் குழந்தைகளுக்கு 9 to 14 வயதிற்குள் HPV வேக்சினை போட வேண்டும். அவ்வாறு போடவில்லை என்றால் திருமணத்திற்கு முன்பாக போட வேண்டும். போட்டுக்கொண்டால் 100% பாதுகாப்பானது. கர்ப்பப்பை வாய் புற்றுநோயிலிருந்து பாதுகாக்கப்படலாம்.
பெரும்பாலும் மனிதர்கள் அனைவருமே வாழ்வின் ஏதோ ஒரு காலகட்டத்தில் HPV வைரஸ் தொற்றுக்கு ஆளாகின்றோம். நினைவில் இருத்திக் கொள்ளுங்கள், HPV தடுப்பூசி போட்டுக்கொள்வதன் மூலம் ஆண் பெண் இருபாலருக்கும் புற்றுநோய் மற்றும் மருக்கள் வராமல் தடுக்க முடியும்.
கர்ப்பப்பை வாய் புற்றுநோயின் பாதிப்பை 2030 ஆண்டுக்குள் இல்லாமல் செய்திட உலக சுகாதார நிறுவனம் இலக்கு நிர்ணயம் செய்துள்ளது. அது 90-70-90. அதாவது உலகம் முழுவதும் உள்ள பெண்களில் 90% பேர் HPV தடுப்பூசி போட்டுக்கொள்ள வேண்டும். 70% பேர் ஸ்கிரீனிங் மெத்தட் பரிசோதனை கட்டாயம் மேற்கொள்ள வேண்டும். புற்றுநோய் இருப்பது கண்டறியப்பட்டால் ஆரம்ப நிலையிலேயே 90% பெண்கள் அதற்கான சிகிச்சையை மேற்கொண்டிருக்க வேண்டும். இதுவே அதனுடைய இலக்கு.
உங்கள் குழந்தைகளுக்கு தடுப்பூசியினை உடனே வழங்கி HPV பாதுகாப்பு வளையத்துக்குள் இவர்களை கொண்டு வாருங்கள்.
நம்ம வீட்டுல நடக்கிற கல்யாணங்கள், திருவிழாக்கள் அனைத்துக்கும் நம்ம எவ்வளவு செலவழிக்கிறோம். ஆனா உங்களுடைய குழந்தைகளுடைய நிரந்தர பாதுகாப்புக்கு, புற்றுநோயிலிருந்து பாதுகாப்பதற்கு இந்த ஒரு சில 100 ரூபாய்களை நீங்கள் செலவழிக்கிறதை பற்றி யோசிக்கவே வேண்டாம். அதனால நிச்சயமாக உங்கள் குழந்தைகளுக்கு, குறிப்பாக பெண்களுக்கு இந்த தடுப்பூசியை போட்டுக்கொள்ள வேண்டும் என்று கேட்டுக்கொள்கிறேன்.
HPV தடுப்பூசி பற்றி மறு யோசனை எதுவும் வேண்டாம்.
HPV தடுப்பூசி போட்டுக்கொள்வோம், புற்றுநோயை விரட்டுவோம். HPV தடுப்பூசி போட்டுக்கொள்ள சொல்வோம். பெண்களை காப்போம், பெண்களை காப்போம்.
So thank you, ma'am. Thank you, Ramani, ma'am. I request Padma, ma'am.
Yeah. Yeah, today's webinar was really productive and it is a very nice presentation from Jayashree. Thank you and congratulations, Jayashree. You are the opening batsman for my TNFOG oncology series. Thank you. Came out very well. And thanks to our
Batsman was so I had to come inside the ground.
Hello?
Okay.
Batsman was missing.
Thank you so much. Thank you. Bye.
Thank you, ma'am. Thank you.
Thank you, Ramani madam. And
Thank you.
Sampath
Thank you.
madam. Thank you.
Dr.
Thank you.
Jayashree, this documentary film was
very beautifully
made
done.
on behalf of TNFOG and Dindigul Society, and Dr. Amala Devi was the brain behind it.
Yeah,
And
very
we have
nicely done.
decided to show this small video presentation to all the school programs.
The first part is you didn't show today, no? First part is also very nice. The first few minutes.
Kindly share this video in the group, ma'am, please.
Okay. It's already we have shared in the TNFOG EC member group. Anyway, once again, I will share that.
Yes, ma'am.
Okay.
Thanks.
Okay. Anybody, when you go for any public program, you can show this. Instead
Yes,
of
ma'am.
giving a talk, I think this will be more self-explanatory.
Yes,
They will
Yes,
enjoy seeing this film.
Yes, ma'am.
Thank you. Thank you so much. Thank you.
Thank you.
Thank you, ma'am.
Thank you. So, shall we close it?
Yes.
Yes, ma'am.
Thank you.
ma'am.
A nice evening to all of you. Thank you.
Thank you so much.
Thank you,
Thank you.
Radhika.
Thank you, ma'am. Thank you, Padma. Thank you all delegates and